Hello, good evening. Welcome to Midweek's Mental Health. Today we are here to talk about all about fits. Fits is a layman's term that is used for a medical condition called epilepsy. We have Jaiswal sir with us. He's a chief neurologist from KIMS Hospitals. He's gonna help us understand more about this condition called epilepsy. Hi, sir. Good
Nice
evening,
to see
sir. How are you?
I'm good. I'm good. How are you?
I'm good, sir. I'm good. So I'm sure everybody knows you. I mean, we have had a very interesting talk about stroke last time,
Yeah.
and that was actually the most viewed video on my page.
Wow. Yeah.
I think you're so good. I mean, even I learned a couple of things about stroke. Also, it helps me understand how to talk to patients who come with stroke with cross consultation. That is great, sir. So today we are here to talk about epilepsy. Sir, I have a basic question, right? People call it fits in layman's term. What is a seizure? What is a convulsion? What is epilepsy? How are they different?
See, seizure literally means to seize. So something unknown, it seizes you. So you are helpless. That is seizure. To convulse is whenever a patient gets abnormal movements of the hand, feet, mouth, tongue biting, incontinence. This is called a convulsion. So epilepsy is basically a series of convulsions. See, more than two times if the patient gets a seizure, it is called epilepsy. So seizure is a single attack. When you say he had a convulsion, you mean that you're describing the seizure, the activity. But a convulsion, seizure, they are used interchangeably. But if you want to say that it is epilepsy, it has to recur. So more than two times if such thing happens, we say he has got epilepsy. That's
Right.
it.
Right. So obviously, epilepsy is a more serious clinical condition than having one episode of seizure.
Yeah, see, there are many conditions where you can have one convulsion. Like in young children, in infancy, children get seizures when they have high temperatures. So that usually is self-limiting, it gets resolved. Unless they have other conditions like, a brain abnormality or they have got a brain infection, then you need to treat them. Otherwise, simple febrile convulsion we call. Whenever you have fever, you have a convulsion, so you call it a febrile convulsion. And then generally you would give symptomatic treatment for that time. And you take care of the fever and usually things get controlled. But if it recurs, then you need to take it seriously.
Okay. So at what age does seizure start? Usually, is there any age group?
No. You can seize from the time you are born to the time you are dead. So there is no age limit for that. But one interesting thing is, seizures, they affect different age groups differently. So when you have a neonatal seizure, you think of something like metabolic abnormality. When you have a seizure in infancy, that's below 1 year of age, you think of certain things like brain infection and brain abnormalities, brain hemorrhage. Then if you have seizure between 5 to 15 years of age, then there is different set of seizures which affect this age group. Then from 15 to say 35 age group, there is certain self-limiting seizures. They are called epileptic syndromes. Then beyond 35, 50 in the elderly you get a seizure because of say strokes or because of certain tumors if they come in those patients or secondaries in the brain. So the etiology differs in age-wise.
Right. So is there a chance that if a child has a seizure during fever, uh, he'll be more prone than a child who doesn't have seizure during fever to have epilepsy in the future, or is there no relation at all?
No, there is definite relationship that if the patient has little, we call it atypical or complicated febrile convulsions. So in that situation, this person getting seizures when they are adults is relatively high. Now also there are certain underlying factors, like starting from family history of epilepsy to certain congenital anomalies in the patient himself or acquired problems which are epileptogenic. So these are all the factors which would affect the chances of getting seizures when they are grown up, and that is in the adulthood. So that is why in the childhood, when they have recurrent convulsions, we do investigate them thoroughly. We have, say, a simple scan of the brain to look for any abnormality in the brain and do a serial set of EEGs to see whether they are convulsing. They may not be convulsing outside, but if the EEG is not normal, then you need to treat them. And most of the times, by age of 5 years, these things settle down.
Right, right. Back in the day, people used to think when someone has seizure, they're either possessed by spiritual energy or some religious thing. But now we all know it occurs because of abnormal electrical impulses of the brain. So, what are the triggers for the seizures? Are there any triggers?
See, if we are talking about triggers in a patient who is a known epileptic, if he's a known epileptic, generally what happens is, in a person who is a known epileptic, the commonest cause for seizure is missing a dose. They miss their anti-epileptic drugs, they get a seizure. Lack of adequate sleep is one thing. Third thing is, generally if you are already on drugs and still you go on throwing seizures, then there are three common causes. Like you should look for whether he is taking the medicine regularly, whether the dose which is being prescribed is sufficient or not. Or thirdly, is the drug appropriate for that type of epilepsy? Because there are different types of epilepsies. So there are very different types of epilepsies.
Right.
Yeah.
So what is aura?
See, aura is something which precedes the epilepsy. Now, aura is one thing which is felt by the patient, and he feels that his mood is different and he is irritable, restless. He comes to know that something is going to happen and not normal. And most of the patients also know that they are going to throw a seizure. So they know if a patient has aura, he is blessed. He takes care, he goes and puts himself in the bed and sees that he doesn't injure himself. So aura depends on the epileptic focus. See, epilepsy is basically uncontrolled electrical discharges in the brain, which can happen in any part of the brain. Now, depending upon the area, like if it is in the visual area, you get a visual aura, you get flashes of light. If it is in the temporal area, you may get the feeling of nausea, vomiting, tipsy-tossy in your stomach. So these are the feelings one get when you have a temporal lobe seizure.
Right.
So mood changes. So these are it depends on from where the epilepsy is originating.
Right. Okay. So if somebody is having a seizure, right? People next to them, they do all different kinds of things. They give them like a key, like a metal key to hold and things like that. But what exactly can I do if a person next to me is having a seizure? I'm not a doctor. Then what can I do? So what are the precautions?
See, what happens is when a patient is having a seizure, usually they lose consciousness. They tend to fall down. And then because they are not conscious, there is a very high chance that they may injure themselves. So the person around them should do one thing is just pull the patient away from being injured himself. Say if there is fire nearby, get him away from that. Any sharp objects, get him away from there. Our best is to put them on the floor. Second thing is turn them onto one side. If you turn them onto one side, because most of these patients, they'll be frothing from their mouth. So there is excessive salivation from their mouth. So what you do when you turn them from this, you're preventing aspiration. So the respiration is relatively saved. Third thing is this thing of putting objects in the mouth of the patient is very dangerous. And sometimes people put their hand in the mouth of the patient and they injure themselves. So see, there will be abnormal movements of the jaw clenching. That is how the tongue bite happens. If possible, you could just put a soft cotton towel in the mouth if possible. But don't put your hand in the mouth of the patient, and never use hard objects to put in the mouth of the patient, because that will end up with loose tooths, injury, more injury to the tongue or to the mouth. And then if it starts bleeding, the patient is already unconscious, and this excessive bleeding in the mouth itself can cause aspiration and death. So you're traumatizing, or you're causing more harm to the patient than good to the patient. So it's better you just leave him, see that he doesn't injure himself from the external sources, and don't inflict injury on him, like putting hard objects in his mouth.
Right. So, for a seizure patient, like who comes to you when you're treating them, what are the things that you ask them to avoid?
See, the first thing we ask them to avoid is not to avoid his medication.
Yeah.
He should not miss the medication. That's very, very important. The second thing is, we ask them to have good night's sleep. That is very important. There are many types of epilepsies which are well controlled if you sleep well. So if you sleep well in the night, the chances of this epilepsy, like juvenile myoclonic epilepsy, these are all eponyms, that really doesn't matter. But then these epilepsy can be well controlled if you are sleeping well for minimum of 8 hours in the night and avoiding sleeplessness. Now we ask them to avoid certain things. Like if we talk about, so as I told, first is the drug. You should not avoid the drug. You should not miss your drug. Now second thing is, people ask, can I have alcohol? Okay, so alcohol in moderation if you have, then they feel because they have taken alcohol, they should not take the drug. So this is a wrong concept which they have. So we always say that don't miss your drugs, and then if at all you are having occasionally a little drink or something like that, space them, and never, never, never miss your drug. That is more important than the alcohol. That's one thing. Now, third thing is driving. It's a pertinent question, like should they not drive? Now there are various laws and rules for driving in various countries. Like in the UK, maybe you're not allowed to drive for 6 months, and it becomes very difficult in those countries. But our country is blessed. Here we have no control. You can do anything, whatever you want. You had a seizure today, you can drive tomorrow. There's no problem, because there's no control. We don't know. And many a times, it is the commonest cause, again I want to repeat, is missing the dosage, not having adequate sleep, or overindulgence. So these are the few causes where the patient has seizures.
Right. Right.
And another thing, avoiding prevention, I'll use that word now. See, you avoid driving or riding a vehicle without using a helmet. So that's one of the commonest causes for RTA, head injury, and then these patients becoming epileptics. So I take this occasion to say that avoid driving without using a proper helmet.
Yeah.
Or
Not
in
even
the car
the
without a
yeah,
belt.
yeah. Even the people who are sitting behind the driver on a bike, sir, they don't use a helmet in India.
Yeah,
It's almost like they're immune to accidents, which is not true.
they are just they want not to be fined by the policeman. That's it.
Yeah.
They are not worried about themselves.
Yeah. Sir, if I have had just one seizure,
Yeah.
not febrile, but not without fever, I have had one seizure. What are the chances of me having another recurrent seizure in the future?
See, let us look at it like this. Now, if you had one seizure and you know a cause for that, like you have infection in the brain, some bleeding in the brain, some epileptogenic focus, then the chances of you getting a seizure is very high. It is more than 80%, 85%. Now, suppose I had a seizure and my investigations all were normal. Most of the times it happens. That's why people are reluctant to use the medicines. They say, my EEG is normal, my CT scan is normal, so why should I take medicine? Now, in this situation, it's interesting to know that if a patient had a seizure, how do I counsel them? I say your chance of getting another seizure is, if I say, you may get a seizure, you may not get a seizure, he thinks I am stupid. But if I tell him your chances of getting a seizure is 50%, I'm telling the same thing.
Same thing, yeah.
So if I say your chances of recurrence of seizures is 50%, then it is a too high a risk to take. Okay, then you take the help of the ancillaries, you do a scan, you do an EEG, you look at the history of febrile convulsions in childhood. And you had one seizure now. So you definitely need to be on antiepileptics. So history becomes very important. And then most of the times, what happens is the patient takes proper therapy. Like he takes the treatment for say 3 years or sometimes 5 years, because if there was a breakthrough seizure. After stopping the drug, the chance of this patient getting a seizure is 2%. Between you and me, if we have not thrown a seizure all our lifespan so far, our chance, as long as we are alive, getting a seizure is 1%. But if I was an epileptic, I was treated for epilepsy, I have taken the proper course properly, and slowly they have tapered my drug and all that, still me has a chance of getting a seizure 2%. But that is too low. So we were talking about recurrence 95% or 85%, then 50-50. I mean, that is you may not. But if after having taken a treatment also, the risk is increased from 1% to 2%. So see, 1% to 2% is a 100-fold rise.
Yeah.
So then you have to take a call on the age of the patient, the type of work he is doing. See, if he's a driver, I wouldn't want him to stop the drug. So you have to take a call on all these things depending on these facts.
Sir, the mainstay of the treatment is obviously medications. If you put a patient on medication for multiple years, how long he or she should be seizure free for you to probably try thinking of putting them off medications?
So you're talking about the primary seizures where there is no obvious abnormality in the brain. I mean, there is no abnormality which is a focus for the seizures. Now, there is a little difference, some recommendations from the UK, USA, European recommendation or the American. See, the difference is 2 to 3 years is a minimum recommended period where you should be seizure free. Now, it really means that your scan should be normal. Your EEG should have normalized if it was abnormal. And the third thing is that you have to count seizure-free interval from the last fit you had, not from the time you started the treatment. See, after 1 year, I stopped the medicine for a couple of days, I threw a seizure, then again, started the medication. Now I have finished 3 years. So that is not the criteria. It is from the last seizure which you have. And one very important thing at this point is you cannot stop these drugs abruptly, because that may end up with a life-endangering situation. Drug withdrawal suddenly is a very bad thing to happen because your brain has got used to it. So you have to slowly, under medical supervision, taper the drugs. And this gives you time. What happens is when you're tapering and then you get something like a seizure, you get an aura. So then you'll be warned. No, this is not the right time to taper the drugs. So you can take a proper decision.
True. Once, let's just say I had a seizure now. Once I finish having my convulsion, how long does it take for me to feel normal? Do I immediately get up and feel normal, or do I take some time, sir?
See, in these minor seizures which you have, absences. So what happens is the patient is cutting vegetables, they have the seizure, and then they become conscious and they are immediately normal. If you look at their graphs also, it is like that. You have a normal EEG, suddenly you have the discharges and suddenly it becomes normal. And the patient becomes alert. So he does not know that he even had a seizure. Okay, so it's called absences. So in this type of seizures, there is an immediate recovery. But if you're talking about the generalized tonic-clonic seizures, where the seizure has started somewhere and it has spread everywhere. And so these patients, they may be drowsy, irritable. It may be lasting from, say, half an hour to even a day, where they may have a mood change, they may be irritable, they may be drowsy. So it depends on the type of seizure also, and the severity of seizure, and the number of seizures which he had. All these factors may decide. Sometimes it so happens that patient has a focal problem. He gets seizures in the right side again and again and again, and then he develops a paralysis of that part of the part. So then that usually recurs in 2 to 3 days. So it's called Todd's palsy or post-ictal paralysis. So these are very different things in epilepsy.
Right, right. So someone is asking, can skipping meals trigger a seizure if you're already an epileptic?
See, skipping a drug definitely is a cause for um, precipitating an attack. But skipping a meal, see, definitely for all these disorders, especially the neurological disorders, standard lifestyle is highly recommended. It's very difficult to say that just because I missed my breakfast, I had a seizure. But maybe you're taking your tablet after having the breakfast, so you missed your tablet also. So it's more likely that it is that. But I mean, I wouldn't just say, because, missing a meal. Many times you have seen parents are, very particular. They come and say about their children, he's not eating properly. Maybe that is the reason why he's not he's getting seizures again and again. So, I mean, we are obsessed many times about food. I mean, I'm using this word little loosely, but yes, we are obsessed about our food, especially parents about their children, about the eating. But to me, I ask them only one question: does he attend the toilet regularly? If he is attending his bowel movements is regular, then he is eating something, right? And he's having a bowel movement. So I wouldn't bother. So I would counsel them this way. This is one way of counseling. That's it. You need to have a proper meal at proper time. There's no doubt on that.
Right, right. Right. So everybody thinks seizure means you have to fall down and just have a very like jerking movement of the entire body. But a lot of people don't even realize that, even absent seizure in children is also one of the major things. So can you just quickly tell about how does absent seizure look like in children and how they are mistaken for somebody who is inattentive in the class or daydreaming in the class?
Yeah. I mean, generally you pick up these absences from the history. The usually commonest complaint which we get, I'm sure you must have seen so many, that he's not doing scholastically well in the class. So he was a very good student. Now he has become inattentive. He is not writing his notes properly. He is not paying attention to the class, and his grades have gone down. Now, what basically is happening is, unfortunately, the child is having abnormal discharges in the brain. And for that minute, for that few seconds, where his brain is not in uh, synchrony, he is unable to register whatever he is listening. So he is considered this as inattentive. So absence are basically being absent from the class for that one moment. But then physically he is present and he is absent mentally. He is unable to record whatever is being told. So absences can be just a staring look, or sometimes you have this complex partial seizures where you may have few automatisms. See, absences without any particular movement in the body, but sometimes you have complex partial seizures where you have some automatisms like chewing, lip smacking, or making some noises. So these are complex partial seizures. And of course, the generalized tonic-clonic seizure is a popular epilepsy. Like when the patient falls down on the ground, he may have an aura, he may give a loud cry, and then he has jerking movements of the hand and feet. The eyes and head may turn to one side. There will be frothing from the mouth. There will be bleeding from the mouth, and then he may be incontinent, or he may urinate his clothes. So this is a generalized tonic-clonic convulsion.
So, I think. So one more thing, like a lot of people have this thing that, if somebody has a seizure, if EEG comes normal, what next?
See, the diagnosis of epilepsy is made on the history. investigation. See, epilepsy, you investigate by doing an EEG, by doing an MRI or a CT scan, yeah, whatever it is. Now, these are imaging modalities. Now, EEG tells you about the abnormal discharges. If you're lucky enough in those 20-30 minutes of record, if he has an abnormal discharge, he'll pick up. Otherwise, it will be normal. So a normal EEG, you must have seen many of the EEG reports they write, a normal EEG does not rule out epilepsy. So epilepsy is a clinical diagnosis. It is never a diagnosis based only on EEG or a CT scan or an MRI. So there is no test for epilepsy. History. History is very important as to what really happened, how it happened, and many times we educate the patients because sometimes we are confused whether the patient really had a seizure or he's feigning a seizure. I mean, he's acting like an epileptic. So we ask them to have their mobiles and record the activity, because many a times you can pick up what is real, what is unreal. That's very, very important.
Right. True. True. I see most of your patients that you refer, you're very clear about them taking a video. They come and tell me, Jaiswal sir has asked me to take the video and show it to you, and they show. I mean, they all are very proper with videos.
Yeah, it's so handy and so useful, you know. More than a big investigation costing so much of money. Yeah.
Yeah. True. True. So, what's the relation between alcohol and seizure?
See, alcohol basically in moderation really doesn't cause a problem. But we know that alcohol withdrawal, they themselves cause seizure. So alcohol basically sedates you, but then in moderation only. If you tend to overdo anything, so more so a condition called alcohol withdrawal is a difficult situation to treat. And we face this in many times in the MICU. When the patient is admitted for stroke, he's admitted for some other problem, and then he's in MICU and he has been having alcohol every day. So for day 1, day 2, day 3, he doesn't have the alcohol and he starts getting the withdrawal seizures. Then the other thing is, after this alcohol was banned, it was not being sold. We all have seen all these people who are regularly taking alcohol becoming psychotic, throwing convulsions. So they are all benzodiazepine withdrawal seizures, what we see. So this, I think there's a negative relation between alcohol. If you don't take alcohol, you get a seizure. Yeah. More so than if you take alcohol. That doesn't mean that I'm advocating that you should have alcohol.
Yeah, yeah. I mean, that is very, that we should make it very clear. So. Or they'll go and say, because one of my talks I said, like, you can't smoke, especially after 6 p.m. It interferes with your sleep. Apparently, they said that Dr. Charan told, before 6 p.m. I can smoke, it's okay.
To their convenience, they will interpret us. So I think we have to be careful, especially on a forum like this.
Yeah, yeah. I think we pretty much answered everything, sir. So one last question: what are the treatment modalities, sir, if somebody has epilepsy?
Modalities of
Treatment.
See, basically you have the medical management of epilepsy and you have a surgical management of epilepsy. So when you start the patient on one drug, most of the time 60 to 70% of patients get seizure control. Most of the time. Now, sometimes we have to add another drug, which improves the response rate to about 75% or 80%. So again, 20 to 30% of patients are there who are not well controlled on double drugs. If you add a third drug, it doesn't make much difference. When you add a third drug, it hardly, improves the seizure control rate by 1 more %. So it's not worth adding a third drug. So then when you're talking about drug 1, so 50 to 70% you can get control by drug 1 and drug 2. But that's called the add-on drug. But third drug, if you add in, it really doesn't make a difference. So you have to choose your first drug, second line drug very carefully. It has to be appropriate to the type of epilepsy the patient is having. There are certain epilepsies which respond particularly to one. And in these patients, if you give the other drug, you are going to worsen their epilepsies. So this is, most of the doctors know about it. So they will take care of it. Appropriate drug is very, very important. Like, you know, if you're talking about absences or primary generalized, you don't want to give carbamazepine, and it
Yeah.
might be worsening the situation in this patient. And
Yeah.
the surgical modalities used in patients who have refractory epilepsies, difficult to treat epilepsies, who have structural problems in their brain. So, you know, if you take a proper patient and do a proper surgery and get that irritant out, see, the drug requirement comes down over period of time. You may not be on any drugs also. So that is also a possibility.
Yeah. Yeah. So one last question is, a lot of people think that okay, seizure comes and goes. It's not like it's there all through the day. So why should I even take treatment? What will happen if I don't take treatment?
See, the biggest problem if you don't take the treatment is any type of accident. See, you may fall down from the stairs, you may be driving, you may having a serious head injury, and you may be inflicting this to other people also.
Right.
So, why should I take the drug? Yeah, there are certain situations, I agree, but they're rare. You know, some patients they get seizure only when they are asleep. In the sleep, they get a seizure. Now, this is one set of where we discuss whether we really should treat them, we should not treat them. Then again, we think of something called SUDEP, sudden unexplained death, when the patient is already sleeping. It's common in children also. It is common in patients who are possibly having nocturnal epilepsy only. So whatever said and done, you know, it is very difficult to say which patient does not require anti-epileptic. It is difficult. But there are maybe few handful of situations of epilepsies which are self-limited. They go away with age. You don't need to treat them. You know, epilepsy with centrotemporal spikes and things like that. But by and large, medical management, that too I'm talking about the allopathic medicines. I have to tell many times patients that there is no treatment for epilepsy in Ayurveda, homeopathy, and all that. I mean, bluntly, we'll have to tell them that.
Yeah.
Because we have known of cases where people were uh, giving them phenobarbital and phenytoin sodium, making pills out of them and giving it to the people for years and years and claiming that it was Ayurvedic medicine. So such sort of things also, I'm sure you remind of what really I'm doing too. So our ignorance level is very high. So we have to educate people, tell them that this is the same thing which he is giving. And another thing which people come and say that in our village there is one old man, he gives one-time treatment and then they claim that he will never have an epilepsy. So I said, you know, there is the chance of recurrence is 50% or the chance of recurrence is 80. So who is falling in which category? It's very difficult to say.
Right. There are many people in many villages who treat seizures
Yeah.
apparently. All right, so
People almost
I think we pretty
yeah,
much covered all about it, sir.
yeah, yeah. Thank you.
Thank you so much, sir. You have a good day.
Thank
Bye.
you. Good night.
Bye. So, last couple of minutes before we end the talk, what is the relation between mental health and seizures? Is that, the most common type of seizure that is we call GTCS. I don't want to get into the terminologies. 6 to 8% of the patients can come down with psychiatric problems because there's a close association. Whereas different kinds of seizures called TLE, temporal lobe epilepsy, the chance of you having a psychiatric comorbidity is around 35%, which is pretty high. Now, what are the psychiatric problems that you usually see? One is apathy. Apathy is where you don't have will or drive to do anything. So obviously that causes problems in your work life and probably even in your relationships and personal life. Second thing would be lethargy, where you see patients as somebody who is very lazy. Here, this is not about lazy. It is about they not having any motivation to get up and do, they feel very tired most of the time. That can happen. Some people can come down with even psychotic symptoms like hallucinations, delusions. Some people can have depressive symptoms. Some people can have eating disorders as well. Some people can have sexual disorders where there is decrease in sex drive or increase in sex drive. Some people can also have uh, anxiety is that that they're going to have another seizure, because it could be a chronic condition. And also there is a lot of bullying and stigma in the society. So anxiety and depression is again common here, but we should also look for change in the personality, especially in old people. If somebody is suddenly behaving very differently, let's just say I'm a very quiet, funny and nice person, and following seizures I'm behaving like a different person, you can't even recognize who this person is, then you should again consider definitely getting a neuropsych evaluation as well. So please look for all these things if you have a seizure. And in children especially, you have to look for any reduction in the scholastic performance. Your school grades are dropping, and you're being called out by the teacher, and also uh, added on there is bullying by other students, so your school grades will drop more because you don't want to there's truancy, you don't want to go to school regularly. So all these combined together can make a child very listless and lethargic and fatigued all the time and not having interest in studying. But otherwise, child's IQ is fine. Child can fare well if he's put in a proper environment. I think that's pretty much about our relation between mental health and seizures. I think that's our time. I'm assuming that, yeah, somebody is asking. Seizures are very common on child below 3 years of age. In children, especially under 1 year or 2 years, if they have fever, high fevers, they are associated to with seizures, but not in like my age and your age where we have fever. Usually not seen, but sometimes extreme high temperatures can cause seizures in as well. Yes, somebody saying that their nephew gets fits at the age of 4 when the temperature rises more than 102 degrees. That is true. Yeah, I think we pretty much answered everything. Thank you for joining in. You all stay safe and have a good night.